Kidney transplantation. High-yield notes for USMLE, PLAB, and MRCP. Let's break it down. Crisp, clean, and exam-focused. 1. Indications for kidney transplantation. The main cause? End-stage renal disease. From diabetes mellitus, hypertension, polycystic kidney disease, glomerulonephritis, and failed previous transplant. Preemptive transplantation, done before dialysis, has better outcomes than starting with dialysis first. That's a favorite exam point. 2. Contraindications. Know the difference between absolute and relative. Absolute contraindications, these are hard stops. Active infection, active malignancy, severe cardiovascular disease, can't tolerate surgery, uncontrolled psychiatric illness. Now, relative contraindications. Depends on the case. Obesity, non-adherence to therapy, advanced age, judged case by case. 3. Donor types. Top-tier outcomes from a living donor. Best survival rates. Then we've got deceased donors, either brain dead or cardiac death. HLA matching improves graft survival. The closer the match, the better. And don't forget, ABO compatibility is essential. No compatibility, no transplant. Quick recap. Know your indications, lock down those absolute contraindications, and remember, living donors are gold standard. This is high-yield rocket fuel for your exam. Let's dive into immunosuppression and rejection. These are hot questions, so listen close. Then comes maintenance therapy, long-term meds to keep that graft safe. 3 big classes: calcineurin inhibitors, tacrolimus, and cyclosporin, antimetabolites, mycophenolate mofetil, MMF, and azathioprine. Corticosteroids, like prednisone, but with power come side effects. Common side effects? Let's go drug by drug. Tacrolimus causes nephrotoxicity, neurotoxicity, hypertension, new onset diabetes after transplant, aka NODAT, and hyperkalemia. Cyclosporin shares a lot, but also adds hirsutism, gingival hyperplasia. Looks like a dental consult and a wax strip. Mycophenolate. Think leukopenia, GI upset, especially diarrhea, and it's teratogenic. NO in pregnancy. Azathioprine causes bone marrow suppression, pancreatitis, hepatotoxicity. Steroids, the usual suspects: diabetes, osteoporosis, weight gain, cataracts, mood swings, hypertension. This is gold for MCQs. Hyperacute rejection happens in minutes to hours, caused by preformed anti-donor antibodies. Dibody hypersensitivity. You'll see thrombosis, cortical necrosis. Sadly, it's irreversible, requires graft removal. Acute rejection occurs in days to months, often within the first 6 months. Can be T-cell mediated, cellular rejection, or B-cell mediated, humoral rejection with anti-HLA antibodies. Treatment? Start with high-dose steroids. If resistant, use ATG. For humoral, plasmapheresis plus IVIG. Chronic rejection, also called chronic allograft nephropathy, develops over months to years. Pathology shows interstitial fibrosis, tubular atrophy, vascular thickening, and glomerulosclerosis. It's multifactorial, part immune, part non-immune. Unfortunately, it's largely irreversible. We manage by optimizing immunosuppression and controlling risk factors, but eventual graft loss is common. So remember, know your timeline, your mechanism, and the treatment. This is pure gold. for test day. Let's wrap up our kidney transplant masterclass with complications monitoring and infection timelines, plus some high-yield questions to test your brain. 6. Complications. Post-transplant. Infections are a major risk due to immunosuppression. Watch out for CMV, cytomegalovirus, BK virus, causes polyomavirus nephropathy, UTIs, tuberculosis, TB, PJP, pneumocystis jirovecii pneumonia, serious, malignancy risks, PTLD, post-transplant lymphoproliferative disorder, linked to EBV, skin cancers, especially squamous cell carcinoma. Cardiovascular disease is the #1 cause of death post-transplant, also common. New onset diabetes, NODAT, hypertension, often from CNIs and steroids, bone disease, like osteoporosis, steroid-induced, electrolyte imbalances, hyperkalemia, hypomagnesemia, usually from CNIs, monitoring and follow-up. Keep an eye on serum creatinine and eGFR, drug levels, especially tacrolimus, cyclosporine, urinalysis for proteinuria or hematuria, blood pressure, glucose and lipid profile, ultrasound, if obstruction, vascular issues, or rejection suspected, regular infection and malignancy screening. Know the timeline of transplant-related infections. This shows up on exams all the time. Serious, key transplant-related infections. Let's break it down. HSV, first month, mucocutaneous lesions. CMV, 1 to 6 months, fever, malaise, leukopenia, thrombocytopenia, graft dysfunction, pneumonitis, colitis, hepatitis. BK virus, 3 to 12 months, slowly rising creatinine, viruria, viremia. Biopsy shows viral inclusions. PJP, 2 to 6 months if no prophylaxis. Dry cough, dyspnea, fever, hypoxia, interstitial infiltrates. TB, anytime, usually later. Often extrapulmonary, fever, weight loss, cough. Fungal infections, variable timing, think aspergillus, candida, pulmonary or disseminated depending on site. Now for some rapid-fire questions, just like the real thing. Question: a 55-year-old man has rising creatinine 2 weeks after kidney transplant. Biopsy shows dense lymphocytic infiltrate. What's the diagnosis? Answer: acute rejection. Explain. Timeline is key. Within weeks plus lymphocytes screams acute cellular rejection. Question 2. Which of the following is a side effect of tacrolimus? Answer: nephrotoxicity. Explain. Classic. Tacrolimus causes nephrotoxicity, neurotoxicity, and hyperglycemia. Hirsutism? That's cyclosporine. Question 3. Q3. A post-kidney transplant patient presents with fever and leukopenia 2 months after transplant. What's the most likely infection? A. BK virus. B. CMV. C. EBV. D. HSV. Answer: B. CMV. Explains. Classic board question. CMV shows up between 1 to 6 months post-transplant. Key clues: fever, malaise, and cytopenias like leukopenia or thrombocytopenia. Also, it can hit the lungs, gut, or liver, and even cause graft dysfunction. Q4. Which of the following is true regarding chronic kidney transplant rejection, also known as chronic allograft nephropathy? A. Occurs within 24 hours. B. Caused by T-cell infiltration predominantly. C. Reversible with steroids. D. Associated with interstitial fibrosis and tubular atrophy. Answer: D. Interstitial fibrosis and tubular atrophy. This is a slow, insidious process, happening over months to years. Biopsy shows fibrosis, tubular atrophy, vascular thickening, and glomerulosclerosis. And unfortunately, it's largely irreversible. Acute rejection? That's your T-cell player. Hyperacute happens in minutes to hours, not months. Q5. A kidney transplant patient presents with rising creatinine. Tacrolimus level is elevated. What's the likely cause? A. Acute rejection. B. Chronic rejection. C. Drug toxicity. D. Prerenal AKI. Answer. C. Drug toxicity. Explains. Tacrolimus is a calcineurin inhibitor, and yes, it's nephrotoxic. If the drug level is high and creatinine is climbing, you're looking at direct renal injury from the drug itself. Know the timing, the mechanism, and the lab clues, and you'll crush these questions every single time. Thanks for watching. Don't forget to subscribe. Medical Rocket.